Thank you. I'll try to present to you some data with regards to the use of the Verdichizzo. How many in here are surgeons and how many are nurse practitioners? Surgeons? 2, 3, 4, 5. Okay. The nurse practitioners or theatre staff, because a lot of these staff we're going to see. Yeah, good. So it's the last presentation. I'm trying to keep it as fun as possible and speed it up and get the message across. I don't have any conflicts of interest. We've got some conflicts of interest in the department. Transient flow and why we need it. We know that in theatre, some of the grafts will fail. Will fail even before we close the chest or after we close the chest, and definitely before the patient goes to the intensive care. And we know that that could be up to 11%. In the previous presentation, we had some Lima to LAD grafts that they underperformed by the registrars, where I can tell you that some of them have been underperformed by me as well. And this kind of thing can be avoided. We can understand it better, and we can have a better results. And we know that by using the TTFM, the echoes, that is the Verdichizzo system you can see on the screen, we can have the best understanding at the end of the operation if the graft works or not. And I'll demonstrate to you as we go. This is a machine that is recommended by the European guidelines and by the NICE. So out of all the staff that have been in this room, how many have actually seen this machine in their own theatres, apart from the Oxford staff? Good. So some people have it. Excellent. So what the TTFM gives us? It assesses the flow down the graft. How does a graft perform? So you can see down the bottom it's a probe. You put it around the vessel, and it emits ultrasound and trying to calculate speed. And by that, it gives you mean graft flow. So how much blood goes down the graft. And it calculates in 5 seconds or one screen of the machine. And we know that we need to have diastolic filling, meaning that graft should perform during diastole, when the heart is empty. And here in blue, you can see how much diastolic filling goes down the graft. And that diastolic filling is represented with that figure, DF, 86% down the left-hand corner, and that should be over 50%. We also know how much competitive flow we get. So if the anastomosis is not significant, and then you get a lot of backwards flow, a lot of competition, a lot of stagnation, and that something that we can calculate. Finally, we can get what we call the PI, versatility index. And what actually it gives you, the PI, is how much resistant to the flow there is after the completion of your anastomosis. Is it something happening to the anastomosis because you didn't perform it very well and your PI is high? That graft is going to fail earlier, or may not be adequate, as I'm going to show you later on. The ultrasound probe, that is the other component of the Verdichizzo system, it gives you two things. One is giving you a beautiful picture of the anastomosis. It can tell you if your anastomosis is patent. So you can actually do it with an ultrasound, or you can actually probe it. That's a natural, that's the technique that is used across the country, I suspect. And the other thing I can tell you is that you can put it on the aorta, and you can pick up the area, or you can do your cannulation, you can put your cross clamp, you can do your top end anastomosis. So you're safe. You do not actually punch the aorta on top of the aortic flap, and then you go, oops, what's that? It comes out. So let's see the first case. This is a 59-year-old gentleman who had 3 arterial grafts. We finished the anastomosis, and then we measure our flow, and then we get -1 mil, and the PI of 67. So nothing really goes down that graft. So we take the ultrasound probe, we put it on the top of the anastomosis, and we have a wide anastomosis. It's a rima to intermediate. You can see there, wonderful anastomosis. So what's happening? Are we going to close this patient? This patient, if we didn't have a TTFM, and the very key would have been probed it would have been probed up and down, okay, the patient would be closed. Will be sent to the intensive care, and is this patient going to have any ECG changes in the intensive care? No, because the native artery hasn't been damaged. This patient has been having flow down his native coronary arteries. We haven't damaged that artery at all. It's just our graft doesn't work. We haven't given him any extra. So we revised this graft. That was a right internal mammary artery to the intermediate through the back of the aorta, and it was twisted, and we couldn't see it. That's the only way to find out. After revision, you get 52 flow. The graft works. Second case, this is a 3-grafter now with 2 mammaries and 1 vein. This is an on-pump case. So if you see the TTFM on the left-hand side, top is flat. And that is because the measurement is taken during bypass, so it's a continuous flow. You don't have a pulsatility now. So we've done that, and you have a PI of 1. You expect it because the native coronary artery is empty. There's nothing down the native coronary artery. And you expect a very good flow down your graft, and you get only 17 mils. Again, we put the probe on it, and you can see an anastomosis, which is okay, and probably if you could probe it nicely, and you'd be happy and close the patient. Is this an adequate anastomosis? Is this the best we can do for this patient? The answer is no, because you can see the stricture. We over-tied the 7-0 proline, and we're pursuing the anastomosis. So we've redone this one, and then we double the flow. And you can see on the right-hand side now the anastomosis is wide, it's patent, it gets a lot of flow down. So this is an adequate anastomosis for this patient. Probably on both occasions the patient will be free of symptoms, free of ECG changes, okay, because we haven't really damaged the native vessel. And if we look at him and the long-term outcomes in 5 years or whatever, may not have got any problems really. However, the right side, the revised graft, will perform a lot better down the line, and especially in the arterial grafts, we're talking about 20 years. Third case, 2 arterial grafts beating heart on pump. So we performed the anastomosis on the left top hand corner. You get a bit of pulsatility, but the patient is, the heart is beating, but it's on bypass. And then we come off bypass and it goes to almost 0, down to 4 mils. What's happening now? Are we going to accept that? We'll put the ultrasound on it and you get a lot of flow. This is a typical example of competitive flow. There's nothing else you can do. This anastomosis was way overestimated. Probably the patient didn't need to be grafted. Fourth case, this is the last one. Again, 3 grafts, lima and 2 veins. We performed the graft. We've lost now the colors because we lost the ECG, so it's only the line. And you have a flow of 8 mils, and PI, which is the high side, is 5.1. Okay, I've got vivid memories of this patient because all my grafts were going like this. So I've revised every graft 3 times, and I couldn't get any better. And at the end I said, that's it, I can't do anything better than that. I don't know what the machine says, but I can't do anything better than that, and I can't help this patient. So I took him back to the intensive care, I took him down to the cath labs. This patient had a native coronary artery spasm, severe native coronary artery spasm. All grafts are patent. We just put him on GTN, and he came home after 5 days, no problems. So this is an example where the revision was not necessary. So TTFM and ECAS it's a very valuable tool for coronary artery bypass grafts, because it can tell you when a patent graft anastomosis is adequate and when it's not adequate. Because you may have per-string anastomosis, you may have a twisted graft you cannot see because it's behind the aorta. But you have to keep in mind that not all cases of poor TTFM need to be revised, need to have a revision, because you may have a competitive flow or you may have a native coronary artery spasm. And these are some 4 examples where the TTFM and the ecosystem have been very valuable in our hands and changed our practice. Thank you.